Okay, everyone. We're going to get started again. And we have 30 minutes in this session, we're going to report back from the breakout sessions. And we're going to try to take a more interactive approach for this session. And I'm going to channel my Jerry Springer or Phil Donahue and walk around a little with the microphone. So I'm first going to introduce first I'll introduce the three speakers that are going to report back from the breakout session this morning. But I also want audience participation when we address these specific questions and issues. If there's anyone in the crowd who would like to say a few words, please raise your hands and I'll come over with the microphone. This is being recorded, so we do want to have everything on the microphone. So I don't have to introduce Daniel, but I will introduce, for those of you who have not met Jackie Campbell. She is a national leader in research and advocacy in the field of domestic violence and intimate partner violence. She has authored or co-authored over 200 papers, and she is the leading expert and authority worldwide on the topic. So it's really a pleasure to have her on this, reporting back in this role. And Dr. Lanny Berman is our third heavy hitter on this panel. He has been a leader in the field of suicide prevention for decades and has published a great deal, has served on almost every leadership, in a leadership role in many panels to inform the field and to advance the field of suicide prevention. So we have a very distinguished group. And what I'm going to do is I'm going to direct three questions to the panel. And this is based on the breakout session and your discussion in the breakout session. So the first question that I'll ask is about the top research questions that you talked about, top issues that need to be addressed in terms of research to advance the science within your domain of violence. And Daniel, would you like to go first for community violence?
Sure. So to be honest, we didn't dwell too much on the pressing research questions, but what did emerge from those discussions that is missing is we recognize we have far more data availability to look at interventions that are focused in the criminal justice realm, simply because we have convenience of arrest records and so on. When we look at interventions that are in some ways directed at the same problem, same people, and so on, say with the cure of violence, we have more data gaps, simply and partly due to confidentiality and things like that. But one thing that I think Katerina Roman hit upon, which is we know a lot about offending networks. What we need to really explore, the new frontier, so to speak, is understanding social networks of those high-risk individuals and where there are opportunities for bridges out of that network. Sometimes we think of that as sort of mentors or other things, but there are various different programs and strategies. So better understanding not just the offending networks, but who are influential people, who are bridges to get someone out of a risky lifestyle. So I thought that was probably, one of the most unique and challenging issues before us. We also discussed that there's generally a lack of research on the most comprehensive forms of interventions, and that is in part due to you don't see them that often because they're very resource intensive. And two, if you're doing something very, very comprehensively, you certainly don't have a randomized kind of opportunity or something like that. So those are our research challenges and sort of areas to explore anyway.
Jackie, can you, from the IPV angle?
Well, we had a wonderful group, a lively discussion about a number of different intersecting issues. One of the things that we talked about a need for is more and better implementation science in terms of how interventions actually get implemented. We use the LAP, the Lethality Assessment Program, as sort of an exemplar that is being used, but in various iterations, and some of it with, that makes you cringe in terms of how it's being implemented in various communities. Some of it is innovative and probably useful modifications, but have not been tested, and we talked about the need for some comparisons in different models that do have a beginning, a little bit of support or even some robust support, like something like Safe Dates, which has robust support, but not very good support in inner city communities. We also talked about the need in terms of, in the gender-based violence realm, we talk a lot about changing norms. And traditionally, it's been about changing norms of men's relationships with women. It was pointed out that we don't do a lot in terms of different intimate partnerships from people that don't, choose binary sexual orientation, gender orientation, and that's an important issue. But that as important as gender norms are norms around when it's okay to use violence, when you should use violence to protect yourself, under what context, and oftentimes it's around the notion of what it means to be a real man in this society. And for young men growing up, that looks very different in terms of whether or not you should use violence, whether or not you should carry a gun, those kinds of things. And that perhaps the best way to change or to deal with norms of masculinity, especially for young black men, which is, young adolescent black men who have been seriously traumatized in their growing up years, oftentimes, that we need to talk to them about how to change the norms. We need to get from them good, innovative ideas on how to do that amongst their peers. And whether it's gender-based violence or community violence that we're talking about, they both have some of that issue at stake.
Thank you. Lanny, can you weigh in in terms of suicide research gaps, top research questions?
So first I should say I spent many years as a camp counselor, and I just want to say we had the best group. So we had a wide-ranging discussion and spent a fair amount of time on this single question, and an interesting mix of people from mental health and public health. So a fair amount of our discussion about research needs began in the arena of mental health, and the needs that are mostly summarized by the NIMH Research Prioritization Task Force report, which came out a couple years ago, which was intended to spur funding decisions at the National Institute of Mental Health for a variety of questions, such as, and these are some that we discussed, how little we know about the last days of life of people who die by suicide or make significant near-fatal attempts. There are only 5 studies in the literature to date focusing on the last 30 days of life and clinical data that has been observed by a clinician that would inform clinicians or primary care docs to make reasoned decisions and judgments about need for inpatient hospitalization, need for other forms of care, et cetera. So we have a great deal of research on risk factors for suicide, very little with regard to research focusing on the point in time where the intervention is most significant in terms of saving a life. As well, about 25 to 40%, depending on the study, of people who die by suicide are in or have had access to health care in the last weeks to months of life. But that means the majority of people who die by suicide aren't in and have not accessed health care. So there are significant research questions with regard to increasing help-seeking behavior and reaching people in the community who have needs, obviously, for health care, who simply don't show up and aren't referred, or if they are referred, still don't show up. In the same sense, this overlapped with some discussion we had with regard to means restriction or means accessibility issues relative to firearms in particular, where we have pretty good research that we're comfortable with it. This is one of the most significant forms of prevention that we have. At the same time, there remains lots of questions about how do you get people to accept the data that we have, that if you can remove access to a firearm, you'll actually save a life of somebody who's at risk for suicide. We don't really even know what we need to communicate about who is at risk. And so those kinds of questions in terms of the public education, public awareness campaigns remain unconducted at this point. We have some significant therapeutic interventions that have decent evidence base, but if you know the treatment intervention literature for DBT and CBT and CAMS and the other treatment approaches for which there is nice evidence, most of the outcomes are at most 18 months, and the most of the outcome data is on repeat attempts or reduced ideation, but we simply don't have long-term studies that inform us about what truly will move people over the longer term from not returning to the emergency department or not returning to care because they've become suicidal again. In that sense, of course, we don't have very significant number of psychoautopsy studies relative to who the decedents are and how that informs, again, what we need to do clinically. Training issues. We know that the clinical practitioner needs to be better trained to work with suicidal people, to implement evidence-based care, but there is no money for training. Basically, we're not reaching enough clinicians. We haven't yet to find what community people need in terms of better training for awareness and, again, what to look for and how to refer, et cetera. So there are lots of issues around training and research needs relative to that. Let's see if there's anything else of any great significance. So I think the other thing I should mention is that there is a need to better research, no less build collaborative partnerships with people in risk factor fields such as alcohol, in researching how we should be working together to inform our treatments and our prevention programs better. There's more, but I'll hold it there.
So did the panel miss anything? Does anyone want to bring up any research gaps or areas for future research that you feel should be addressed? This is your opportunity to fill in any holes that you see or make suggestions. Okay. No takers. Okay, so we'll move on to the next. The next domain to report back on is evidence-based strategies. So what are the most promising evidence-based strategies? You can think of this universal strategies, selective, indicated. So Daniel, would you start and just, did your group discuss any evidence-based strategies?
Yes, that's mostly what we discussed. And I'll just say from the outset that when you talk about community and youth violence, there's no way you can cover the whole spectrum in this kind of condensed thing. So what we did is we zeroed in on the most promising, and particularly towards the more lethal end of the spectrum. So we know in the law enforcement, criminal justice realm that hotspots policing and problem-oriented policing that's addressing very, very specific high-risk individuals and places, particularly around high-risk behaviors, dealing with guns and alcohol in particular, have a very good track record of success. Focused deterrence is a strategy that we discussed and has a very robust evidence base to address urban gun violence. focused deterrence is something that involves law enforcement and criminal justice, but also partners that with available services as well as community supports. And in, I think, more recent iterations, something that's being appropriately stressed is more procedural justice and legitimacy issues. Cure violence is a public health model that has a growing body of evidence to support its impacts. However, there are a number of communities where it did not have the intended outcomes, but in terms of the direction of sort of innovation, I think New York City is really complementing some of the outreach and violence interruption components with wraparound services and other important complements to it. I think in the health system realm, there's some promising areas with respect to counseling parents around gun storage, gun access, as well as some new emergency department motivational interviewing kind of approaches. It seems to me that there is a lot more that is being done and needs, we need to develop that evidence base because a lot is going on in health systems that we still need to study.
It's very surprising that a lot of the approaches that you just mentioned were discussed in our suicide group as the most promising best practices.
Interesting.
So, room for synergy. Jackie?
We talked some about, particularly about lethal domestic violence in terms of the efficacy of some of the or state laws that prohibit both purchase and possession, importantly, of guns from known domestic violence offenders when there's an order of protection. Part of the drawback there is that the offenders who are most likely to come to the attention of the criminal justice system are those who are Black, that there's a great discrepancy there in terms of, who we're holding accountable around domestic violence issues. But there's also, and April did a very nice job, and she has a fabulous recent, April Zioli, that is, I'm pointing at her as if you're all supposed to know who she is, has a fabulous recent analysis that was published of these laws. Implementation is also an issue in terms of those laws, especially around, as we heard in the Texas church shooting, where a known domestic violence offender, where that offense never got into the database, so he was not prohibited from purchasing multiple weapons. So, there's that implementation thing is a piece that you always have to be careful of when you look at the results that give you some promise for evidence to go forward. The other thing, there's a lot of mixed evidence around the efficacy of things like offender intervention programs. And there's one exciting new intervention, Strength at Home, which is for veterans who use violence in their relationships, that addresses their trauma as well as their use of domestic violence with significant RCT trial reductions in both use of violence and PTSD. So, that kind of approach might be something that we want to do more of in our community offender interventions. Problem is now, most of the offenders who are in those intervention programs are only there because they've been arrested for domestic violence. So we have some of the same built-in kind of biases that happens. And So the other things we talked about is screening and providing a warm referral for domestic violence in the healthcare system. And there's, again, some mixed evidence around there. It definitely does increase connection with services. It does not necessarily result in a reduction of domestic violence. I always say, well, duh. You know, why would we think that just asking somebody about domestic violence would reduce their repeat domestic violence? So it needs to be what happens after the screening in terms of actually helping those who are experiencing domestic violence be in touch with the healthcare system. The sexual assault realm, also we have a little bit of evidence around a few things that might be helpful there. And again, one of the things we talked about is what are the innovative partnerships between criminal justice and advocacy interventions or community services for those who have experienced gender-based violence. And what are the barriers for people using the criminal justice system? What are the possibilities for making that? Because, you know, as much as we all recognize we're not going to be able to arrest our way out of domestic violence happening, at the same time, women are still going to need to be able to call the police when things are really horrific, when they're in fear for their life. So, you know, we're going to have to continue to have some partnerships there, continue to provide police training around how to be effective at the scene of a domestic violence call. We need some more around sexual assault reporting also in terms of how to make that work. Forensic nursing, sexual assault nursing exam are part of that picture, getting that information out. But there needs to be these community partnerships that are both around, you know, early interventions, prevention strategies, addressing trauma of witnessing domestic violence in your home as a prevention strategy for young people, but also continuing to evidence-based and continuing to test these interventions, but also be sure that they work in many different communities, not just where it's first convenient to test them.
So Lanny, I know there's some overlap, and any unique discussion from the suicide group on evidence-based
Yeah,
practices?
I think there's a lot of overlap. And again, our discussion was wide-ranging, so I'll try to encapsulate that fairly quickly. I think as a group, we would probably agree that the quality of the data relative to reducing accessibility to means is better than what you saw on the screen this morning. And there is reasonable data in the UK on paracetamol, which is their version of extra-strength Tylenol, and national legislation to reduce access. There is a terrific number of studies on bridge barriers worldwide. There's some pilot studies on reducing access to pesticides in agricultural countries that are largely agricultural, where that's the #1 method of suicide. And of course, our firearms data here, which is, from my perspective, I think from the group's perspective, is clear that if we can indeed reduce access and promote attention to people at risk in the process, we're going to save lives. Second area, I think, is, again, more clinical, where we have good data relative to treatment interventions, be they DBT, CBT, various methods focused on continuity of care once somebody is hospitalized after a suicide attempt, for example, and making sure that once people are discharged from hospitals that they are maintained in a system of care. The problem, of course, there is what I mentioned earlier in terms of training and the reach of that training. The people who need to know simply don't know enough. There aren't a significant number of clinicians who are trained in these approaches, and defining better ways to, on a population basis, to get these trainings implemented and obviously then used by people. And the third, which I think is probably most profound now in the wave of the future, and represents the mix between mental health approaches and public health approaches, are these integrated, coordinated healthcare strategies that involve multiple components in communities, in states, within healthcare systems. This got spurred first by the Air Force back in the 90s, and as Holly mentioned this morning, it was terrific data until they stopped implementing the program, and then bad things happened. An article in Lancet back in 2012 by Wiley et al., where they had terrific data on multiple component healthcare intervention in their outpatient clinics, and showed significant reductions in suicides and attempted suicides. And now the movement, sponsored mostly by SAMHSA here in this country, relative to zero suicide, all with an intent to involve multiple components into an integrated caregiving system. So I think the data has been there. It's yet needed to further reinforce this kind of model. But that's the wave of the future for interventions.
So any other innovations, Daniel or Jackie, that were mentioned in your group that you would like to talk a little bit about? We just have about a minute left. Or were they already covered?
The one thing that comes to my mind, especially when we start talking about the suicide, is the somewhere around 38 to 40% of domestic violence homicides are followed, of women, are followed by suicide of the offender. And that those look very different. Those domestic violence, those homicide perpetrators are more likely to be white, more likely to be middle class, but they have made suicide threats in the past. And many of them had been to healthcare providers or mental health care providers. And so again, I think what can be considered innovative is when we try and go across these areas of violence. And with the suicide, I also think a lot about our indigenous populations and how they are experiencing horrifically high rates of suicide, as well as domestic violence, and how that history of trauma intersects there also.
Thank you. And let's thank our panelists for reporting back. So right now we're going to break again into breakout groups. In this room, and you check the back of your badge. If you're number 1, then you're in this room. That's the Police Criminal Justice Service Sector group. If you have number 2 on your badge, you're going upstairs to room 4013 West. That's the health breakout session. And number 3 is West 4019, School Community breakout group. And I believe there'll be people in the back of the room to take people upstairs to find their rooms. So thank you, and we'll break now. Welcome back, everyone. I'm just going to go ahead and welcome you and introduce the speakers. So Catherine Bradshaw is a professor and the Associate Dean for Research and Faculty at the Curry School of Education at University of Virginia. She also is part of our family at Hopkins and has been for a long time. So we welcome you. And Tenny Gross is the Executive Director of the Institute for Nonviolence in Chicago. He also has great expertise from a practitioner's perspective in working in outreach with outreach workers and in lots of different roles and in different cities. David Kennedy is a professor of criminal justice at the John Jay College of Criminal Justice in New York City and the director for the National Network of Safe Communities. And when he's back, John Rich, who is also going to join us in the front, is a professor at Drexel in the School of Public Health, and his work is focused on serving African American men in urban settings, and he was awarded a MacArthur Foundation Genius Award. So we're going to switch things up a little bit with this breakout, and we're going to talk about systems change this time. In our group, personally, we focused a lot on the impediments. So it was useful, but we'll also talk about some of the other important types of systems changes that are needed in order to make progress in the prevention of violence. So I was hoping that we could hear from David. If you could share with us what you think the most important types of system changes that are needed to prevent violence, that would be terrific.
In 2 minutes or less.
Yeah, and getting to model this. All right, so I apologize to the room. You have all already heard too much from me. Dan just asked me to do this, and I said yes against my better judgment. So I'm going to try to be really quick here and then invite other folks who are part of this conversation to tell me what I got wrong or to fill things in. So very quickly, I think the conversation that we had was about the ways in which, for the most part, a lot of the productive changes in violence prevention, and our conversation was pretty heavily focused on the criminal justice component of that. But I think what I'm about to say is also true for medical and public health work, that the most effective changes have been driven by a kind of combination of desire from top-level practitioners in a position to move their organizations and to change their mission and hold their own organizations accountable for those changes. That relatively little of that has come from being enforced from the outside. So statutory change and consent decrees and all those sorts of things matter, but a lot of the conversation of frustration and impediment was about things that are either should be happening or are allowed within current statutory frameworks, may even be required by current statutory and accountability frameworks, and aren't happening because the people in positions of responsibility don't care enough to get that work done. The conversation went to a very interesting place, which was about, particularly in a Baltimore context, the tremendous gulf between traumatized and alienated communities and the Baltimore Police Department. That was a Baltimore conversation. It's one that could be replicated all over the country. And that conversation went to a very different kind of engagement that we're seeing modeled across the country, which are really outright, more or less formal apology and accountability and reconciliation engagements. And a lot of commentary from community people that they would be willing to come to that table. Could people just stop lying about what was going on? We'll show up and we'll listen and we'll participate. So what I want to end on here, and this was not entirely part of the conversation, but I want to add it, which is that I think one of the, as we say, there's things that work and we should focus on principles and not on programs, is that the sort of action research practitioner role that a lot of folks like people in this room seek to play can be very effective in being in the middle ground between scholarship and organizational practice in different communities and help move through that terrain in a respectful and cooperative way and get new things done. And that's an important role, and it's probably something that is at least as important as sort of formal structures of authority. Is that close enough?
That's great.
Okay.
So the idea of reconciliation and sort of what that looks like, I'm just sort of, if anybody from our conversation wants to say anything more about that, because I thought that was maybe one of the most important take-home points. It's just, Dan would just be honest with us, you know, just how fundamental that is. Anyway.
So Dr. Rich, we would love to hear your perspective. Right now, we're talking about the most important types of system changes that are needed to make progress in violence prevention. So feel free to report back from your group. Love to hear your insights in general on this issue.
So thank you, and I'm going to ask the folks who are in the room to weigh in also. I think that the group focused on some very specific opportunities for intervention around suicide. We heard about the Kaiser system and steps that are really being made to both identify predictors and measure and incorporate into clinical practice powerful mechanisms for decreasing suicide. We talked a little bit about specific impacts on intimate partner violence and thinking not only at the individual level but at the community level about what kinds of opportunities are possible. We're not only thinking, we're thinking about the intersection between race and violence and gender in those settings. Talked about specific hospital-based interventions. And I think as we began to talk, we began to realize the interconnectedness of efforts around suicide, intimate partner violence, community violence, and certainly in the pediatric setting, we're seeing all of those things happen at the same time and in hospitals. And I think we began to talk to some extent about the system-level impacts. And so from my perspective, there is a relationship between, or similarities between the criminal justice system and the healthcare system, and that they are both systems that had in their foundations encoded racism. And therefore, and even I think more recently, again, if you take, as I do, Michelle Alexander's work as that it's not like the new Jim Crow, it really is the new Jim Crow, then those systems have been complicit in creating many of the circumstances that we've seen. Healthcare and criminal justice have, can think about racism in systematic ways, about how you change your practice at an institutional level in order to improve the health of communities. I think that in terms of bold efforts, we certainly know, for example, I would share with you that Sarah Brain at Princeton has talked about system avoidance and the notion that people who are under surveillance, particularly by the criminal justice system, tend to avoid other systems that gather information on them. So the impact of aggressive criminal justice enforcement in the community, particularly when it is based on race, creates barriers. And many of you who work in healthcare systems will know that the likelihood that people will provide accurate information when they come into the healthcare system is partly dependent on their sense of what that will happen with that information. So our ability to follow up with people afterwards is a function of more than just their level of trust in the healthcare system, but it's the ways in which these systems come together. And so we begin to talk about bolder opportunities for collaboration. And I think about the work of Glenn Martin in New York, who really, when people began to talk about reforming Rikers, he began to talk about closing Rikers and mobilize people to an eventual conclusion that didn't seem like one that was on the table. And so as we began to talk about opportunities for systems, and Josh can elaborate on this, we began to talk about hospitals that are being held to outcomes at the community level. So what would it mean if you said to a hospital, your outcomes will, your payment and your resources will be dependent on educational outcomes in the community, or safety, violence, reduction in the community. Hospitals are really, healthcare systems are really good at solving for the thing that gets them paid. And so we've sometimes made those very narrow. What if we made them more socially related? The other thing that we've begun to talk about in a lot of settings is it possible to connect the outcomes that different systems are creating so that if a hospital implements something that results in decrease in involvement with the criminal justice system, is there any way that there is some shared savings amongst these various different systems so they are invested not only in their own outcomes, but other outcomes? Josh, do you want to say more about what you were? I thought that was great. Right.
Would anyone else like to weigh in on the comments that Dr. Rich made? Any
I'll say one more thing, which is that, to John's point, I think that there are medical interventions that healthcare can do a lot better for the issues of violence. That's sort of, and then there's beyond medical, how the healthcare system, as $4 billion of the economy, can really mobilize. Thank you for a more broader impact. And in a lot of the work that I've done is thinking about incentives in healthcare, and it's very hard because it's not just the dollars, it's the culture and all the other kinds of incentives that are there. But I do think you're starting to see a shift towards broader ways of thinking about the outcomes of health and using outcomes to really encourage a cultural change within healthcare. And if people aren't aware, in Vermont, for example, the entire state is being held to the number of suicides and overdoses as part of contingent on getting a huge amount of extra federal funding. It's the first time at a population level that's been built in. And so we've been getting calls from Vermont health systems wondering what they can do better and how they can work more collaboratively. It's the beginning of a discussion. There will be another meeting about how healthcare can use educational outcomes like absenteeism or dropout as core outcomes. I think that has a potential in alignment with other payment changes to be helpful.
Can I just say one other thing, and that is to what Josh was saying. I'm fond of and I shared this with the group, a quote that Ichiro Kawachi says, just because aspirin cures a fever does not mean that lack of aspirin is the cause of the fever. And I think that the reason I raise that is that when we talk about these root causes like racism and poverty, there's a tendency to want to push them aside as unachievable, or of course, yeah, we're never going to solve those things. But I think there are approaches that are, while we're doing the programmatic approaches, we can also think about what an anti-racist, anti-sexist agenda would look like. And that's not pie in the sky. There are institutions, I would point to the Boston Public Health Commission, that is taken on as part of their core root, creating an anti-racist, which means you're examining what about your institution is leading to the inequalities and making it a high priority on the agenda to create that. So that we're not so far from that if we think about these systems and the ways that they interact with one another. And I would hope that even as we begin to measure some of these things and report them out, we're thinking not just about race, but we're thinking about the concept of racism as the cause rather than some other vague other thing that we're not quite specifying in terms of race, which often in many people's minds slips away to something biological or something that ultimately is counterproductive to the arguments we're trying to make.
So I'm just going to ask the school group, Tenny and Catherine, we talked a lot about relationships and relationship building and a variety of other overlapping themes. So I'm hoping you can jump in.
Great. We both wanted to kind of share some different perspectives on this. We talked both about the community setting as well as the school, and in many cases the overlap thereof, citing some of the violence data that Philippe and others had shared with the group. But I just wanted to pull out a couple of themes that I thought were very salient in the conversation about systems change, is that there is no one solution that this is going to work the same way in all different systems. And that's very unfortunate for those of us that are researchers and want to have an evidence-based strategy that we can replicate and test in all these different settings. And so the idea that this is an iterative process that includes a top-down approach with policy and a lot of high visibility leverage points, but then also the grassroots approach. And sometimes the top comes first and sometimes the bottom comes first. But we got to figure out where they can both meet in the middle, and that this might look a little bit differently in the different settings. And Terry's work a lot in working in Rhode Island and Baltimore, some examples, as well as what you've done in Chicago and Boston, I thought showed really nice examples of how we're trying to get to a similar solution, but often taking different approaches. How we can also capitalize on events that might occur. Unfortunately, we've all been touched here in the Baltimore area by events following Freddie Gray's death, and that created a lot of mobilization and visibility around that. I now live in Charlottesville, Virginia, and nothing like a bunch of white supremacists coming onto your campus to get you talking very differently about the history of racism in our culture and our community, and that goes very deep in a place like Charlottesville, where you've got Jefferson in the history of the institution. So I think there are these kind of moments where we can capitalize on some of the institutionalized racism that come up, and how can we capitalize on those to really move the conversation forward and involve researchers in that process, as well as thinking about data, systems, and practices that can move us in that area.
So we had, Phil was discussing some of the school work that's been done here in Baltimore. One number that stuck in my head was 80% reduction in school arrests, partially by training staff there, and that's important. In every city, it's not always just all bleak news. There's really systems that work well and not, because you got to remember it's a lot about leadership and management and training and making clear decisions. So there's things in, someone's asking me here in Chicago that we're doing really well, like BAM, and there's other things. So it's not always all just bleak. It's just really where we see weaknesses in management. Vanya and other people were talking about the mentoring, and that exposed me to an interesting discussion. At certain ages, you got to really make adjustments in what mentoring looks like. How do you reach deeper, different population? How do you do mentoring for young people who've been more in trouble? And then Billy was speaking about the whole story of the LA reform. And I think not enough people know about how LA changed, but it didn't just happen overnight, right? You know, it was a crisis, there was an opportunity, but there were some brilliant minds working on it, some former rivals who got together and put change above anything else. And it really changed the minds and hearts all the way down to the cops on the streets and parks, reclaiming spaces, a lot of important lessons of success. That are very, very important. I would ask you as a public health field that to be more assertive. You know, Baltimore is struggling. Is John Hopkins sitting on command staff? You should demand that. You know, doctors are not operating at John Hopkins without scientific knowledge. How do we allow public servants like the police to continue to do that without, we're not some ivory tower liberals. You know, we're not the enemies of Fox News. We are, actually, but I'm being here. But we need to start being assertive. We're spending billions of dollars on research and knowledge. This is not some funfair for elites. This is actually a knowledge to save life, and I would ask you to assert yourself. I think that's kind of what we did in Boston, right? We didn't ask permission. We walked in and let's make it happen. I think that I was speaking a little bit about it's not enough to have model on what's happening in the room. If I look back at my role in the last 25 years, you need to have, I don't know how to call, colonels, right? You're maybe the generals, you're the thinkers above, you're the Pentagon. You need colonels who are willing to go in the trenches. And I reversed after the Boston experience when we lost 75% of the outreach team. I was one outreach worker within 2 years. And when I got to Rhode Island, I decided that I won't spend as much time thinking about the young people we need to help. I'm going to make it my number one job to take care of people who are taking care of the young people. That's a change of a shift, right? So I had $1,000 per staff member of interest-free loans for crisis, approved by my board. We shifted how we work to keep them, to take care of them. And that's something, it's almost like we need also a management group as part of this field. People who do management. How do you support people in nonprofit to do it? And then David and I also talked about Boston. Pulling levers to me means another thing. I like to be an organization that's fairly small, but I completely believe that I have the right, and I act on it all the time, to completely change the behaviors of very big systems. I don't like to work in them, but that means my targets are police, hospitals, schools to start with, and universities, and bring them together. So that's part of our, as leaders, be that glue and change very big systems' behavior. And I would also say, don't overthink it. It cannot just be happening just by training on models. The third component, which is extremely, extremely important, is relationships. So I'll close by saying that in Chicago, I've been there for 2 years. I already did 500 one-on-ones. There's no shortcuts. I cannot just come, this is the model from the East Coast, and we brought LA. One final point is radical collaboration. In Chicago, there isn't going to be one model. We were a monopoly in Rhode Island. In Chicago, we brought in Cure Violence, UCAN, a lot of groups. There's about 50 groups now involved, from funders all the way down. Not me, I didn't do it, I participated in that we got to work together. There's risks to that, but ultimately you have a lot more buy-in, I think. It's promising.
So is there anyone who would like to speak up? Great. And the topic is systems change, but it's a free-for-all, so anything you'd like to bring. Thanks.
Hi, thank you. I'm Elizabeth Letourneau. I'm in the Department of Mental Health here at the School of Public Health. And I just wanted to bring everyone's attention, those of you who are in Baltimore, interested in Baltimore, to some wins that we have had in systems change. To Catherine's point about a combination of top-down and bottom-up collaboration and the need for both of those kinds of systems change, we successfully, and I say we, I wasn't involved in it, but Baltimore successfully, from the grassroots level, fought off a decision to build a new juvenile detention center that was supported by our Democratic governor, who wanted that detention center built. And they fought against that. And that's a beautiful example of, I think, grassroots bottom-up work that really helped alter the landscape of the city. We know that even brief encounters with detention sideline kids from achieving normative goals like graduating from high school, even really brief entrees into juvenile justice, and detention is not the alternative. At the same time, we have the Annie Casey Foundation here in Baltimore. It's headquartered here, and they have a 25-year-old juvenile detention alternative initiative that has achieved enormous success in 300 now different sites across the U.S. in keeping kids out of detention. But 2 years ago, they started a movement to close youth prisons. And that movement now has several states on board that have closed their youth prisons, recognizing that some kids may need brief, short-term, supervised residential facilities, but that those need to be close to home, they should be short-term, they should be connected to their parents and figuring out how to make the home a safe place to keep this kid and not substituting prisons for homes. So there have been, I think, some successes here in Baltimore. There's still certainly a long ways to go. Our governor just this week, our Republican governor just this week said, we need to get tough on crime. And so he's burnishing his Republican credentials for whatever reason by hearkening back to something that we know is a failed solution to the issues that we face. But know about the movement to close youth prisons. I think it's something that can only be to the good for kids, and if you have an opportunity to support it, please consider supporting it. Thanks.
Thank you, Elizabeth. Any other successes in changing service delivery to improve the prevention of any of the types of violence?
I don't actually have a success, but one of the things that I think is missing and that I think people in Baltimore in particular are trying to do a lot of work around and nationally is this focus on economic and housing stability as a very key way to reduce violence and to improve overall health outcomes. And I think sometimes we end up there's been discussion of this, and there's been discussion of the communities that are lacking in resources, but I really feel like on a national level and on a regional level and on a local level, we have to be able to address these economic and housing stability issues, and we have to address them as a health problem. And the connection to ACEs and the connection to violence and the resorting to violence in order to actually achieve the economic stability and to be able to support housing is so key and it's so critical. And in the field of intimate partner violence and sexual assault is at least half the reason why women and children continue to stay in these violent relationships, because they do not want to be in the shelter system or out on the street, so they're staying in those relationships.
Okay, I think we're going to, that was great. I think now we're going to transition to the next part. We're going to talk about policy. Thank you for our panelists.
Congratulations on your work, and keep at it.
I am going to go through this part quicker than I initially intended to. I'm going to encourage everyone after me to follow that. to hit our high points. We're behind. I've loved this discussion. But if we're going to have population impact, in addition to all the things we're talking about, I think addressing some fundamental issues with policies around guns, drugs, and alcohol has to be part of how we get there. I'm going to talk about the gun part and touch upon the three areas, three types of violence: community violence, partner violence, and suicide as well. I think what I have learned over a little more than 25 years doing this stuff is, again, something consistent with some points that Thomas App mentioned, having to do with risk. The focus on risky people and accountability systems. So that is going to be the what I will focus on is expanding our really low standards for gun ownership and legal carrying, systems of accountability that only begin with background checks, and talking about reducing illegal gun carrying, legal and illegal gun carrying. Sorry. So we published something a few years back looking at the 13 states with the lowest standards for legal gun ownership, and one of the important take-homes from that is simple enough to just put it in one pie chart, which is if you look at those people who were incarcerated for committing violent crimes with guns in those 13 states, only 40% of those were legally disqualified to use the gun that they used to commit the violent act with. The red part of the slice of the pie is the 29% that would have been prohibited had they been in a state with higher standards. So our standards across our 50 states vary quite dramatically and importantly, and any kind of background check system or accountability system, how large an impact is going to be dependent upon how much of that risk group you are actually addressing with your standards. This was demonstrated on something that April Zioli led, a study that I'm very proud to be connected to, where we did an update on some earlier work that we and some others have done, looking at firearm policies and their impact on intimate partner homicides. Most of the prior examinations have looked exclusively at very specific prohibitions for domestic violence, such as having a restraining order or a misdemeanor disqualifier for domestic violence specifically. What we found that I think is maybe most important is that in states that had a broader violent misdemeanor disqualification for guns, and importantly, just in terms of equity and justice component to this, these are not lifetime prohibitions. They typically don't go more than 10 years, for example. But if you know something about what we talked about earlier, trajectories, keeping firearms away from someone during their riskiest part of their lives could make a big impact. So we found a 25% reduction in intimate partner homicides associated with having violent misdemeanor broad disqualifier, not just for domestic violence. The other important thing that we learned from this study that just came out last week in American Journal of Epidemiology is, again, consistent with this basic idea of how broad were the disqualifiers and what were the accountability systems to actually implement those disqualifiers. So many of you know that our federal laws and state laws aren't so great with respect to domestic violence restraining orders and how narrowly they identify what a romantic or intimate relationship is. When they cover dating partners, which is far more the norm and more where the risk is with respect to the time of life, we found a 14% reduction in partner homicide. But without that broader disqualifier, you did not have statistically significant effects. Similarly, we had a larger effect when the temporary or ex parte orders were covered in the firearm prohibitions. And then finally, just on the implementation side of this, many states did not have explicit laws to that prohibited people have to actually relinquish their firearms when they have a restraining order. We again found that it took that to really have a measurable effect, a 12% effect. What about accountability measures? We've looked at gun dealers, problematic gun dealers, bad apple gun dealers, whatever you want to call them, for a while now. And what we've found in a variety of different studies is that when you actually put them under the microscope, you do undercover stings, and in some cases even sue them, magically the rate at which the guns sold by those gun dealers that get into the hands of in use in criminal contexts drop fairly substantially. We found that in Chicago, Detroit, and New York City. We've looked at getting to this basic idea of how do you prevent diversion, trafficking, call it what you want, to prohibited individuals. The four kinds of things that we've looked at are a licensing system for purchasers, comprehensive background checks. We know what that is. You extend those background checks to private transfers as well. A very robust regulation and oversight of licensed gun dealers, as well as a mandatory theft and reporting requirement. Generally, the pattern of findings is that permit to purchase has a very strong effect in preventing diversions of guns for criminal use, as does comprehensive background checks. We only found that with dealer regulations that we actually did measures of what law enforcement were actually doing. And surprise, surprise, you only get the protective impacts when they're actually acting on the regulations that they can. We also, those are all cross-sectional data. We were able to look in Maryland, where we transferred beyond just comprehensive background checks to address three important things in the Firearm Safety Act of 2013. We extended our requirements to have a purchasing or licensing system. We gave teeth to our regulations that the state police could enforce on bad apple gun dealers, and required mandatory reporting of theft. We found in a study recently published 75% reduction in measures of straw purchase and diversions of guns connected to that. The type of policy that we found to have the largest effect in reducing mortality, like homicides and suicides, is a purchase permit or licensing requirement. We found the sort of opposing effects depending on whether a state like Missouri, which had the system in place for decades, repealed it in 2007, and in Connecticut, where they adopted those measures in 1995. In Missouri, we find a twofold increase in diversions based upon the gun trace data, coincident with that policy change to get rid of their permitting system, which was the mechanism for comprehensive background checks. We also saw a very abrupt, coincident increase in the difference. This is basically a difference between Missouri and the rest of the countries in terms of its firearm homicide rates. Now, that the last large jump upward is post-Ferguson. So while I'm talking about we measured and estimated our impact through 2014. We estimate a 20% increase in firearm homicide rates. That translates into about 50 additional gun homicides a year connected to that policy change. No other state, none of the other 49 states had a larger per capita increase in gun homicides over that period. We also, in a separate study, using separate methodology, found that suicide rates with firearms also increased significantly. And because suicides are more common, suicides with guns are more common than homicides with guns in Missouri and in most places, actually the number of lives that this policy change costs were more on the suicides ledger than on the homicide ledger. Looking at Connecticut, we saw the mirror opposite. If you look at the first 10 years post policy implementation of permit to purchase, we estimate a 40% decrease. We extend that out to 18 years, 29% decrease using synthetic control models. Similarly, we find firearm suicide rates declined significantly, 16% as well. What about comprehensive background checks? That's the thing that we hear most commonly talked about. We've been studying this along with some colleagues at UC Davis, Gary Wintemuth's team, and so far we've been looking at policy changes in 4 states, 2 states that had comprehensive background check requirements and repealed them in 1998, and 2 states that adopted the policy in the mid to late 90s, Maryland and Pennsylvania. Very briefly, what we found is no effects. Why do we find no effects? It seems pretty foundational, and I think it is foundational. You cannot have a system to keep guns from dangerous people without comprehensive background checks. I think the take-home message is it's necessary but not sufficient. What we've been able to determine from data from Maryland and Pennsylvania is that, by and large, the law has been ignored. And we can talk about reasons for that, but it turns out it's the way the laws are structured. A, they're not so easy to get convictions, and B, when you do, there's typically no consequences. The only change we saw to that was in 2012, end of 2012, when Pennsylvania had increased its penalties for straw purchase, and we saw a 10-fold increase in number of cases brought. So it's an interesting conversation because we need to and will continue to have the conversation about punishment, incarceration, and protective effects, but I think it's consistent more generally that if you have no system of accountability, you will have no impact. Last thing I'll just going to focus on is right to carry. It's very much in the news right now. House backed a concealed carry reciprocity law just recently, and it's going to go to the Senate. I'll tell you about that in just a minute, but I want to give you a picture of how much things have changed in the United States since, say, 1980. So this May issue means there's a lot of discretion and not many permits to carry issue, which you see is more the norm back in 1980, or even no issue. They weren't issuing permits to carry guns around, concealed guns around, in even states like Texas. Only one state had no permitting requirement whatsoever, which was a very rural state of Vermont. Look how this map changes. Here's 1990, shall issue. Shall issue is what we call right to carry. 2000, look how blue we're getting. I should have done the colors differently, I realize that. Here we are in 2017. 12 states, you don't need any permit whatsoever. Carry that loaded concealed firearm with you on your shopping errands, wherever you want to go, in some places to bars and whatever. This is what we look right now. What's going on? Whoops. What's going on in Congress? Oh, wait, what do we know about these? Well, we know some really bad research came out that helped actually facilitate what I just showed you, that change. If you think research doesn't matter, this wasn't all a function of bad research from John Lott, but it played a role. So initially it looked deceivingly as if those laws were just really great. They were reducing violent crime until you actually look more carefully. More recent studies find precisely the opposite, that it actually generates more violent crime. I think the most impressive study of these is one completed recently by John Donahue and his colleagues at Stanford. And what you're looking at here is on the x-axis, you look at the number of years a right to carry law is in place and the percent increase in violent crime on the y-axis. So what you see is for every year, in essence, that more people are getting permits to carry concealed guns, that becomes a more normative process. You get what? More violent crime. And it tops out near 14% when you get to year 10. So this is nationwide reciprocity, basically lowers our incredibly low standards to the lowest common denominator, and it's principally because you can go online right now, if you're a legal, you don't have any disqualifiers, you can get a permit from Utah probably, tonight if you want one. And then under national reciprocity, you could carry it in Maryland, New York, or any place you want. Place-based restrictions accepted. So if New York says you can't bring it into schools, you still can't bring it into schools. But that's what. I'm going to leave you with this. And this is what I think is a hopeful sign. And in many ways, there's some deep divides in how we think about guns based upon political party and whether you have guns or you don't have guns. We asked a question in our 2017 gun policy poll. Something very basic. You get a license to drive a car, you're demonstrating you can safely drive it on the road. Do we have anything close? Should we have that in play, something at least resembling that for concealed guns? And 83% of Republicans, 83% of gun owners say, yeah, that sounds completely reasonable. But guess what? We don't have a single state that comes close to that. And it's so completely at odds with what the federal bill does, which is take us completely away from any standards whatsoever. So I'm going to end there, actually, because in the interest of time, I know I was going to cover some stuff about illegal gun carrying, but that's sort of come up in some other conversations. That's an important part of this whole equation. We have to depress illegal gun carrying, but I feel like we've covered that. The next part is we're going to talk about drug policy, and I don't think there's anybody better to talk to us about gun policy than Mark Kleiman, professor from NYU. The floor is yours.
Thank you. So I was asked to talk about specifically what changes in illegal drug policy would reduce violence in the illegal drug markets. Well, duh. Legalize the drugs, right? Then there are no illegal drug. Then there are no illegal drug markets. So then the question is, why not? And the answer is that, not going to be surprised to anybody in the public health business, except on that narrow issue of drug policy. Turns out that if you let people do whatever they want, some of them will harm themselves. And it turns out that that behavior is more common around psychoactive drugs than it is around tennis shoes. Right? So that you should expect a certain amount of self-harming behavior to happen when people are allowed to get whatever drugs they want. You should expect more of that self-harming behavior to happen if they're allowed to get drugs in commercial markets with for-profit vendors, most of whose profits come, or most of whose revenues come from people with bad habits. Because most people who use any drug, except nicotine in the form of tobacco cigarettes, and I'll come back to that, most people who use any other drug use it in moderation and without much damage to themselves or others. And yes, that includes the opiates, that includes cocaine, that includes methamphetamine. Most of the people who use those drugs use them occasionally and with no obvious damage, typically 80% of the users. And those people account for typically 20% of the market. The other 80% of the market is people who use a lot. It's the Pareto rule. And the result is that if you have a legal market in an addictive psychoactive, the people in that legal market are going to be entirely devoted to creating and sustaining addiction. It's true in the alcohol market. 80% of the alcohol sold in the US is sold to the top 20% of the drinkers, ignoring the non-drinkers. The top 10% of drinkers, and in order to get into that slot, you have to have 4 or more drinks a day on average year-round. The median member of that top decile consumes 10 drinks a day on average year-round. That group accounts for 50% of all the alcohol sold in the US. If you are a cigarette smoker, the probability that you will die of a smoking-related cause is about 0.5. Smoking is going to kill you about half the time before something else kills you. So one way to think about it is that being a cigarette smoker is half a suicide. Suicide's not going to happen right now, but basically you're taking a 50% chance that you're going to die of that before you die of something else. Being a very heavy drinker, being a very heavy heroin user, not very different. So from a public health point of view, it's not at all obvious why we should want to encourage the commercial exploitation of the fact that some people develop bad habits around psychoactives. And there's likely to be a trade-off between the harm to self that comes from substance use disorder or irresponsible behavior around drugs generally, and the harm to others that comes, particularly violence, that comes from illicit markets. That's not a trade-off that has an escape. So let me give an example. Again, likely to be familiar in this room, at least to the public health folks. Everybody who's a good public health person wants to essentially abolish cigarettes. And the Food and Drug Administration, using its new authority, is about to issue a notice of proposed rulemaking that would require that the nicotine level in cigarettes be at a sub-addictive level. That is, in effect, they're going to prohibit the conventional tobacco cigarette. We already have about a $10 billion a year market in illegal cigarettes, almost all interstate tax evasion, cigarettes from Virginia going up to New York. Not a lot of violence in that market. There's some. There's not a lot of enforcement in that market. There's some. What happens when we take a $100 billion cigarette market and say you can only get those cigarettes illegally? Well, we've got two choices. We can not do much enforcement and allow there to be an enormous illicit market, which has social problems associated with it, even if nobody's getting arrested and nobody's getting shot, because also nobody's building a good resume entry. Or we can do enforcement against that illegal tobacco market and have it look like the cocaine market. Or we can pick some compromise. But I just remind you, there are 430,000 deaths a year due to cigarette smoking. It's not obvious to me that the public health approach is to allow cigarettes to continue to be sold as they are now. I think we should take some cost on the illicit market side, even on the violence side, if we have to reduce the death toll from smoking. Now, as it happens, there is an escape clause from that one, because people are addicted to nicotine, but they die of smoke. You can split the nicotine off from the smoke. Vaping does that, heat not burn does that, snus does that. Lots of evidence that those are strong substitutes for smoking. If you make smoking more expensive and regulatorily more difficult, and ease up on the non-smoking, the non-combustible forms of nicotine use, you might very well be able to convert the entire smoking population to non-combustible nicotine use without generating any noticeable illicit market. That seems to me like a reasonable way to go. But that is not the orthodox public health viewpoint. The orthodox public health viewpoint is that tobacco companies are evil, and therefore we should have an abstinence-only approach to nicotine. So now let's look at cannabis, right? So we are legalizing cannabis. The word hasn't come to everybody, but we're legalizing cannabis. We have eased up so much, even where the stuff is still illegal, that the price of a gram of THC, which is after all the active agent, has fallen by about a factor of 6 since 1992. Even in states where it's still completely illegal. The price of an ounce hasn't gone down much, but the THC content has gone way up. What probably not many people in this room know, what nobody in the world seems to know except a few of my friends and me, but John Calkins figured it out just from the national survey data. 25 years ago, the fraction of people who report on a survey that they've used cannabis in the last month, who also report that they used it on 25 or more days in the last month, technical term, by the way, is chronic zonker. That fraction 25 years ago was 9%. And my view back then was, this is not a problematic drug. 9% of anybody will do something stupid about anything. Go back to sleep. As the price of THC has fallen, and as the social stigma on cannabis use has decreased, that fraction has gone to 40%. The modal form of cannabis use in the US is heavy daily use, because it turns out that the near daily users use about 3 times as much per day of use as the more casual users. They're well over 85% of the market, and that's not any less true in the states that have legalized. THC content has continued to soar in the legalized states, and the prices in the legalized states are really collapsing. John Calkins and Steve Davenport report that Colorado and Washington prices are falling at about 2% per month. And in Washington, there's now something called Budget Bud, which is 18% THC outdoor grown weed. 18% for those of you who are my age is about 4 times the potency of anything you were getting in college, for $95 an ounce. Or as I think about it, 15 cents per stoned hour. So, do we want to do that? I sort of doubt it. What could we do instead? We could legalize on a non-commercial basis. And we could keep prices high with taxation. We could have, this is Stan Glantz's formulation, and though I agree with Glantz about nothing else, I think he's exactly right on this. We could have a cannabis policy that looks like our current tobacco policy, not like our current alcohol policy. Right? It's an idea I described many years ago as grudging toleration. Okay, you want to smoke weed, be my guest. But we're going to discourage it. Right? That's our view toward tobacco. You want to smoke, okay, we're not going to make it illegal unless the FDA goes ahead with this current thing. But we're going to restrict where you can do it. We're going to make it expensive. We're going to tell you you shouldn't do it. We're going to create stigma around smoking. And all of that's been quite effective in reducing the number of smoking-related deaths without prohibition. So that seems to me like a reasonable policy to think about for cannabis. I don't think those options are available for the opiates or for cocaine. And I think the experiment of the last 20 years about what happens when we ease up on the opiate supply ought to convince anybody who believes that supply doesn't matter in the drug markets that they need to rethink their position. What we can do, keeping those drugs illegal, is reformulate enforcement around minimizing violence. Because the fact that you decided to control the drug by making it illegal doesn't mean that adding enforcement resources is going to substantially reduce consumption. The illegality does most of the work as long as you do a little enforcement around it, and increasing enforcement is likely to increase violence and other kinds of social harms. And you can focus your drug enforcement on violent dealers and violent markets. That's a hard story to tell. So now let me get to the bad drug. Right, I said there's usually a trade-off between harm to self through substance use disorder and harm to others through illicit markets. Well, in the case of alcohol, we've managed to get both enormous harm to self and enormous harm to others, including enormous amounts of violence, by taking an addictive intoxicant that's also an aggression releaser and making it a commercial product. About half the homicide in the country is performed by people who were drunk at the time. And a substantial number of additional homicides are committed on people who are drunk and decided it was a good idea to insult a football player. So, again, I think we have an alcohol policy that looks more like our tobacco policy. 3 specific ideas. The easy one is to raise alcohol taxes. We know from Phil Cook's work that a 10% increase in the tax on alcohol, or in the price of alcohol, which is about a doubling of the tax on alcohol, leads to about a 3% decrease in violent crime. We could have that tomorrow without kicking any doors in. Instead, the Congress just put through a big tobacco alcohol tax cut in the current tax bill. This is madness. For the limited number of drinkers who are really a problem, they get arrested. South Dakota has shown in the 24/7 system that if you say to somebody, there it was mostly drunk drivers, okay, you want to stay out of prison, you have to come in twice a day for a breathalyzer, 7 a.m., 7 p.m., and it has to be 0, or you go to jail for 1 night that night. Doing that turns out to reduce domestic DUI recidivism by 50% over 2 years, even though the process only lasts about 3 months. And when you put it in at the county level, this is all Bo Kilmer and Greg Majet's work from RAND, when you put it in at the county level, you get not only a 12% reduction in drunk driving fatalities, you get an 8% reduction in domestic violence calls, even though it's not a domestic violence program. And if you look at all-cause mortality, countywide, total population, all-cause mortality, countywide, it goes down 4%. No, I did not drop a decimal point. It goes down 4%, and all of that decreases among women, even though 75% of the participants are men. I mean, this is big enough to reverse the case in Deaton finding. And in 10 years of brilliant success, with 4 terrific papers on it in the American Journal of Public Health, that program has spread all the way from South Dakota to parts of North Dakota. Nobody else has picked up this absolutely perfect program. And if you don't have a drunk driving program, screw it. Do it with any kind of alcohol-related offense. The lowest hanging fruit in violence reduction, other than simply raising alcohol taxes, is to tell people who are problem drinkers that they have to stop drinking. And disease model be damned, they will in fact stop drinking. 99.5% of those scheduled tests are taken as scheduled and passed. Now, about half the people screw up at least once and spend 1 night in jail, and most of them don't spend a second night in jail. Yes, they've got drinking problems, but they can control their drinking if they know there's a consequence tomorrow. One more point on drugs and violence. Fetal alcohol exposure is a violence catastrophe. Carl Bell did something that never would have occurred to me. He went to Canadian prisons and he said to the prisoners, "Can you get me your baby pictures?" 40% of the men in Canadian prisons, when you saw their baby picture, showed the characteristic facial features of FAE. So I know this is an anti-feminist thing to say, but women of reproductive age who were sexually active and not using a foolproof method of birth control have to be advised that they shouldn't drink, because unfortunately, the maximum vulnerability of the fetus to FAE is at about 6 weeks, before lots of people even know that they're pregnant. It turns out, however, that there's stuff you can do perinatally to remediate the effects of FAE. It's apparently largely a choline deficiency, and you can just choline supplement at birth, reverse a bunch of the problem. Carl claims that you can even do it in adults. And again, the violence effects of FAE, you know exactly what alcohol does, fetal alcohol does to the brain. It's exactly what you don't want hurt. It's all the self-command mechanisms. So that seems like an enormous one. Finally, we just have to get drug policy out of the hands of the anti-drug fanatics and the legalization fanatics and start treating it like a serious public health problem. Thanks.
I'm going to ask Dean William Pridemore to come forward and talk to us a little more about the most important drug relevant to violence, alcohol.
Okay, so my name's Bill Pridemore. I'm Dean of the School of Criminal Justice at the University of Albany. Thanks to Daniel and to Holly for putting together this great symposium and for inviting me to be a part of it. I really appreciate it. What I'm going to talk about today is probably not terribly exciting. With suicide prevention, individual level analyses and clinical responses get the most attention. With interpersonal violence prevention, a different type of community level approach than what I'll be talking about briefly today provides really compelling stories. So what I'm going to discuss is not terribly compelling, I don't think, but it can be effective. And that's what matters when it comes to harm reduction, especially with violence. So I'm going to be talking about alcohol and violence, the harm reduction potential of community and population level policy. Just by way of introduction, my main theme is that social structure matters, that social structure, policy, and population health matter when considering violence and the alcohol-violence association. Suicide and interpersonal violence are not solely individual actions. We know violence rates vary substantially by demographic group, by geography, and over time. Violence rates also respond to structural conditions and to shocks to the system as well. And the first few things I'm going to talk about don't have anything to do with alcohol, but I just want to get the point across that suicide and homicide do respond to these shocks to the system or various structural conditions. The first example is a study that I've just completed with a colleague of mine at Iowa Sociology. It looks at the impact of the 1980s farm crisis on male suicide rates in farm-dependent areas. This is what that looks like using autoregressive integrated moving average techniques. We see that at the beginning of the farm crisis in January 1980, more or less, there was an immediate and permanent 10% increase in male suicide rates in the in those rural farm-dependent areas. There were not increases in any other places in the United States during that period, by the way. Another example, some work that we've done is the impact of the collapse of the former Soviet Union on homicide and suicide rates, and this comes from some work that I've done with some colleagues of mine. This shows the blue is suicide, red's homicide, green is alcohol-related mortality. You see there were decades long, I don't want to press the wrong one here. I don't know if there's a, anyway, so you see that there was a sort of decades-long increase over time in each of the forms of mortality in Russia. Then here you have the anti-alcohol campaign in 1985 that Gorbachev instituted. You see dramatic decline in rates of homicide and suicide at that time. That only lasted for 2 or 3 years. They started to regress to the mean. And then when the Soviet Union collapsed in 1991, 92, you see some sharp increases again right there. The final example I'll use of homicides and suicides responding to structure shocks or to policy is a classic one of the Washington, D.C. gun law in 1976 from a study that was in New England Journal of Medicine from Colin Lofton, Dave McDowell, and a couple others. This is a little less high-tech. Last night I just copied and pasted from my PDF of this article. But these are, on top are the gun homicide, and on bottom, gun suicide rates. There was an immediate and permanent decline of about 25% of gun homicides and gun suicides as a result of that policy.
What was the policy?
It was a range of policies, but essentially you could no longer buy as possession. So you can no longer buy, sell firearms. Those that had firearms they were given some time frame for which they could turn them in, that type of thing. So the main point that I wanted to get across there with this introduction is that you can't train and deploy enough psychologists, counselors, social workers, community workers, and others to meet the unique needs of individuals and families and implement what we know about the individual level alcohol and violence association. We can, however, employ community and population level policy and other public health levers to more efficiently reach broader populations and to reduce harm. And I think that alcohol policy may be one of those types of levers that we can use, and I want to talk a little bit about that now. So there are a few, I'm going to summarize in very simple terms a handful of community-level interventions and alcohol policies that might have an influence on violence rates. Both suicide, but most of what I'm going to talk about now are more interpersonal violence, and I'll come to suicide at the end. So a set of these policies, first of all, revolve around alcohol availability. Studies have shown that communities where there are more restrictive licensing policies when it comes to alcohol experience faster declines when violence rates in general were going down than alcohol-related violence relative to communities that had less restrictive alcohol policies. Other studies have shown that reducing alcohol outlet density in communities reduces intimate partner violence, and we know more generally that alcohol outlet density, especially with off-premise outlets, curiously enough, but pretty consistently we find this, are strongly associated with interpersonal violence. Another set of policies revolves simply around alcohol sales restrictions and reducing or restricting operating hours. Studies from multiple nations have shown if you simply just restrict the operating hours of when alcohol outlets can sell alcohol, you're going to get a reduction in violence. Another type of these community-level policies revolve around business practices or responsible retailing practices. One of the things that we can do is to modify or attempt to modify the drinking context within bars themselves. And the Safer Bars program, which teaches bouncers and servers to recognize and try to attempt to peacefully diffuse potentially violent situations, has been shown where it's implemented to reduce the number of violent events. Banning glassware doesn't reduce violence necessarily, but it does reduce the risk of injury that can result from violence in those settings. And it also, interestingly enough, increases feelings of safety among the people that are there in those settings. And there are other responsible retailing practices that could be associated with violence reduction as well. A few studies here and there suggest that reduction in happy hour sales, very cheap beers. Maybe I shouldn't say this, but when I was a kid, they actually had penny beers at the place down the street, and then when I was in college, it was dime beers, and now maybe it's a little more. I don't go to those places anymore. But at any rate, very cheap beers, not serving intoxicated folks. All of these types of responsible retailing practices can have, studies have shown, can have an effect on reducing interpersonal violence. There are also a few potential population-level interventions that I want to talk about now. And most of these are actually going to relate to suicide, except for the first thing that I'll mention briefly that Mark also already mentioned. If you increase taxes, which usually increase prices, not always, but usually, if you increase prices, and including, by the way, some recent research has shown having minimum pricing on alcohol, both of these reduce excess alcohol consumption in a population, and both have been shown to be associated with a decline in some violent crimes. Now, the last thing I'm going to talk about is a set of alcohol policies. So this is not exactly a type of alcohol policy, but I'm going to talk about a couple nations that have instituted nationwide alcohol policies that had an effect on suicide. I'm talking about suicide here now, by the way, not interpersonal violence. These two examples come, one from Slovenia and the other from Russia. And so they come from very different nations in all sorts of ways. And I think this may actually be the reason that Holly invited me to talk today, because she saw me present on these fairly recently at an NIH symposium on suicide. So the first thing I want to talk about is this alcohol policy and suicide in Slovenia. A little bit of background. First of all, these national alcohol policies are not just national, local alcohol or state alcohol policies as well, if we take a look at their implementation, provide us with unique natural experiments that we can take advantage of. But there are actually very few population-level studies of their effects on violence. A little background about Slovenia. Slovenia has an interesting mix of beverage preference. Given its history with the Austro-Hungarian Empire, this contributes to a tradition of beer drinking in the nation, and heavy beer consumption actually in the nation. Its geographic location, a lot of people don't think about Slovenia as a great wine grower, or a great grape grower and wine producer, but its geographic location presents an ideal climate for viticulture, and they have in the small country 3 different wine growing regions. And so there's an equal mix of beer and wine consumption in the nation, each of which represent about 45% of the overall alcohol consumption there, with spirits making up the other 10%. They also have very high suicide rates I should mention also that their rates of consumption are over 14 liters per person per annum, which is among the highest in Europe. They also have high suicide mortality rates at the beginning of our analysis, or the years included in our analysis, excuse me. The standardized death rate due to suicide was about 30 per 100,000. For males, it was about 50 per 100,000. So they they passed a new national alcohol policy in 2003. It was implemented in March of that year. It was actually a suite of laws. There were several different things that went into this, including establishing a minimum drinking age, limiting where and when alcohol products could be purchased, and there were several aspects of that: sporting events within certain distances of schools, at certain times of the day, not opening until a certain time, etc. So I'm not really going to talk about the dated method. We're not here to talk about the ins and outs of the autoregressive integrated moving average techniques. That can get pretty boring for most people pretty quickly. But all I will say about this is we looked at the total and sex-specific monthly suicide counts of suicide. And we not only looked to see if there was an effect, but using these techniques, you can see what that effect, the functional form of that effect, like what it actually looked like. Was it an immediate effect? Did it take a little while to occur? Did it happen immediately but then decline back to the mean, that sort of thing? So what we found was this. First of all, there was no effect of this alcohol policy on females. For males, however, there was an immediate and permanent decline of 10% in suicide for males. So as soon as the policy was implemented, and by permanent I mean over the course of the time, obviously, that we had in our study. So this is the step function that I just mentioned briefly. 10%, that is when we're talking about the effects of a policy on something like suicide across an entire nation, 10% is an enormous number or proportion. Now I want to talk quickly about alcohol policy and suicide in Russia. So Russia is a special case when it comes to alcohol consumption in some respects. Volume of drinking is very high. I say here over 16 liters per person per annum. At the beginning of our time period of our study, it was probably closer if you include unrecorded alcohol consumption, probably closer to 20 liters of pure ethanol per person per annum. They binge drink. On average, that's a pattern of drinking. It's one of only 2 nations in the world that the World Health Organization puts into its riskiest drinking category in terms of heavy episodic drinking. And the beverage preference is vodka, which what I have come to term over the years in my work on Russia. Vodka is a very efficient ethanol delivery vehicle. Okay, you're binge drinking vodka. You get a lot into your system before you even know before it even hits you. They also have very high suicide rates in Russia, about 50 per 100 for males, which is second highest in the world, about 9 per 100 for females, and about 28 to 30 for overall, which is 2 to 3 times higher than in the US and in most of Europe. So they implemented this policy. It passed in July 2005, implemented in January 2006. There was a secondary implementation of some parts of it in July 2006, and we took that into account in our AREMA models. Here, they were looking to regulate the production and sale of ethyl alcohol and alcohol-containing products. I don't really have time to talk about this, but there was very little regulation before. I have a whole list of another slide in here if anyone wants to see it later of all the different things that they did. And it included also trying to get rid of the sale of alcohol-containing products like certain medicinal tinctures and colognes and things like this that were being sold by the gallon. Let's say you wouldn't normally sell cologne by the gallon, but that's what these companies were doing because it was much cheaper per unit of ethyl alcohol, and the really hardcore drinkers were buying this and drinking it. But at any rate, there's a whole set of things they did with that, the same types of design that we had here that I won't talk about. And here are the outcomes. Just one second. For females, again, there was no effect. There was a slight decline from the pre to the post-intervention mean, but this was explained by the ongoing systematic variation in the time series. For males, there was a step function. Again, there was an immediate and permanent 10% decline in male suicides. By the way, you want to know just what that translates to, and I'm saying that 10% is a big effect. There were about over 40,000 suicides, male suicides, in Russia per year, right before that policy took effect. 10% of 40,000 or so is 4,000 male lives that were saved, not total, that were saved every year. 4,000 men that did not kill themselves every year as a result of this policy. One curious thing that I'll mention here as well is that you see that the results in Slovenia and in Russia are very similar in scope. That is, there was an effect for males and not for females. They were similar in their, or not similar, the same, in their functional form, an immediate and permanent decline. And they were very similar in effect size, about 9 to 10%, even though these countries are very different in terms of their size, their culture, their beverage preference, the different types of laws that were implemented, et cetera. Okay, so I'll finish up here now by saying, so what? What might all of this mean for alcohol policy and outcomes like homicide and suicide? First of all, we still need to learn more. We need more and better research on different types of policy interventions. We need to evaluate more of the effects of taxation, minimum pricing, alcohol availability, et cetera. We need to study and be prepared to respond to shocks to the system, economic contractions, natural disasters, and other types of events. You can't avoid these risks. They're going to happen. What you can do is understand them better, know how they influence things like alcohol consumption, homicide, suicide, and so therefore be prepared to manage the risk for violent outcomes and other negative health outcomes as well. We need to take advantage of the spatial variation that exists to better study the Alcohol Violence Association at the state level, the city level, and community level, because it's mostly at the state and cities where alcohol policy is set and implemented. And so we need to take advantage as much as possible of that spatial variation. We need to take advantage of temporal variation, including these natural experiments like policy or privatization. So what happens to alcohol consumption and suicide and homicide and other violent outcomes when an ABC state, let's say, privatizes? What happens when outlets close or density quota to homicide, suicide, other intimate partner violence, other types of violence? When outlets close or density quotas are put into place. So we need to take advantage of this temporal variation, including the natural experiments. And we need to take advantage of inequities in violent victimization to understand the Alcohol Violence Association. So to come back to the main theme that I said I had is that social structure matters. It influences levels of risky drinking. it influences violence rates, and it has differential effects on different groups in different places. So we need to recognize the harm reduction potential for the population health levers, including various types of alcohol policy, as efficient ways to reduce violence. That's all I have.
Yeah, what I think I want to do here, in interest of time, maybe we'll just take a couple of questions, but I'd like also, our next panel is going to, what I think is a very natural transition. If policy matters, systems change matter, how do we achieve those? What are some of the political processes and models to do that? I hope that I didn't mess up your slides, Josh, when I was... I was fishing around for my own. But let's first just see what questions or comments folks have. None? Yeah.
So I've heard, I don't know, I want to ask you, I know marijuana has some negative effects, but I've understood that for people that have chronic pain, some of them now use marijuana, and maybe that's reduced some of their use of opiates, which in some cases has reduced addiction to opiates and or death from opiates. Is that even true?
The answer is more likely than not. The evidence so far is only ecological. I look at it, I can't tell another study that gets me there. So it looks to me like substitution, either simply cannabis for opiate as a pain reliever, or cannabis potentiating opiate pain relief leading to less opiate consumption, or, and all of these are possible, cannabis substituting for alcohol in combination with opiates leading to less opiate overdose death. So that is a noticeable benefit of loosening up on cannabis. Not clear how long it's going to last. I had assumed that the big benefit of loosening up on cannabis would be substitution for alcohol, and I'm sorry to say the data simply do not support that. Biggest disappointment in drug policy in the last 10 years, as far as I can see, is that you're just not seeing any substitution for alcohol. And the general lesson here is that patterns of substitution and complementarity matter and are pretty radically unpredictable. And possibly contingency dependent, right? Are there ways of legalizing cannabis in ways that minimize people's combination use? And I don't think we've even started to explore that yet.
Okay. I think we're going to transition to our final panel. And to lead us off is Josh Horowitz. Josh is the head of the Educational Fund to Stop Gun Violence, as well as the political arm of that organization, the Coalition to Stop Gun Violence. And I'm proud that he's also a member of our faculty who teaches health advocacy and a favorite of our students. And I hope that he won't be too mad at me if I screwed up his slides. Are you there? You good? All right. All right. Take it away, Josh.
All right. Shannon, did you want to say something first? Or? Okay. So I think we're supposed to have a discussion here too. So I'm only going to go for about 10 minutes, and I think there's some other presenters, and then I think Shannon's going to have some guided discussion. So I'm going to be sort of quick, give you a little bit of analysis. But I work for the Educational Fund to Stop Gun Violence. It's a C3 organization. We're a research intermediary. We work with a lot of researchers, and what we do is we turn evidence into policy. I have a sort of a C4 arm, which means that I have lobbying potential, lots of lobbying activity as well, but I do two things. We develop policy, and then we turn it into lobbying, into policy, so into laws. So this is I teach a health advocacy, introduction to health advocacy, and this is sort of the basic model that I work with. When we do great advocacy, we need wonderful research on the basic science and also power and political struggle analysis. We need strategic engagement, which means who are your partners? And then we sort of have to do the influencing the media, influencing public opinion, influencing policymakers. Now, a lot of folks think that the role of researchers stop at the top, at basic science. You do the research and, hey, we're done. We'll publish it and that's that. My classes make it work in the world. In other words, your job doesn't end when you submit your research to a paper. That's when it begins. And so especially in some of these other areas in strategic engagement and influencing public opinion, when you want to get a scientific finding or research finding or intervention that you've piloted writ large into law, into policy, so that the institution, whether it's government or a university or a corporation, you want to change policy, there's consequences of not following these policies, you need to do a number of these other things. And so one of those things is building, is when we look for allies, typically we think of what are the other organizations that we can work from? What are the other groups that we can organize? What's grassroots organizing? I believe that scientists themselves have a role in that organizing, and that coming together, they can have a very powerful voice to complement some of these other organizational and grassroots organizations. I'll talk quickly about that. And then, of course, from the influencing policymakers, the voice of scientists, of public health professionals is incredibly important. And I'm going to tell you a very quick story about how that all came together in 10 minutes, and then I'll answer, I guess we'll start and do some questions and answer. Okay. People may recall, anybody from California here? You may recall a terrible shooting at the University of California, Santa Barbara. The shooter killed 6 people, injured 14, and eventually ended up killing himself. Prior to that, his mother had said, there's some kind of change in status of my son. Can we do an intervention? He's posting violent videos. He's involved in minor skirmishes around campus. What can we do about that? They asked law enforcement to come visit the young man. They couldn't do anything about it. He didn't meet any type of criteria to be prohibited. And even though he had just bought 2 weapons and 500 rounds of ammunition, there was nothing they could do, the law enforcement could do, to really remove those weapons and to stop that chain of, to intervene. Even though California has some of the most interventions available, this person wasn't, didn't seem to indicate that he was a danger to self or others. He didn't have a felony conviction. There wasn't anything they could do. Okay. 4 months later, we ended up with a new policy, which gave law enforcement the ability to get something called a gun violence restraining order, to remove a firearm from someone not who's a danger to self or others, but is substantially likely to commit harm. It's a lower standard. It's an order that a temporary order lasts for 21 days. The full order lasts for a year. They have to go to a judge, family members, or law enforcement can do that. It gives people time to get the firearm out when a crisis is in the midst of developing. That law went into effect January 1st, but it passed in 2014, maybe 60, 90 days after this shooting. So was it just luck that allowed us to get this law done in 60 days? Or was it the act of a lot of committed, both grassroots activists, but also people who are public health professionals? And the answer is it wasn't just good luck. First, the development of that law started way before Isla Vista shooting. We had really good science, not perfect science, but we knew that the DVRO, the Domestic Violence Restraining Order, which we based on, was based in science. We had some really good translational reports that I'll mention really quickly. We had great stakeholders. We were able to work with consumer mental health groups who are often very concerned when we're taking guns away from people who might be at risk of harm because they don't want to be stigmatized. And we had some great people on the ground. There's something called a gun table in California where people have worked on gun policy for a while. And we had a draft bill. Why did we have a draft bill? I'll show you. This is a consortium for risk-based firearm policy. These are some of the original formulators of this, and so with some support from the Joyce Foundation, with some of my colleagues from Johns Hopkins, Shannon and Daniel, and now April, and some other folks here. If I forget to mention you, I'm sorry. But we brought, in this room, in 2013, we brought together some of the best thinkers in public health and mental health and law enforcement to say, what do we know about the risk of guns and mental illness? And it turns out, I'm not going to go into all the detail, but we came up with a set of policy recommendations that really minimized the role of mental illness, but really looked at risk and contemporaneous gun removal around high-risk individuals. And we brought some wonderful people together to think about that, and we published 2 reports. This was the federal report, this was the state report. In that was the recommendation for the gun violence restraining order. It was based on a Connecticut statute that had been used, but not a lot. We identified it, we built it out, we included some new components, and we finished that day and we said, you know, we're going to stick together. It was a conference like this, and we said, we're going to continue this, and we're going to form something called the Consortium for Risk-Based Firearm Policy, and we're now planning our 4th meeting. We've been together. Oh, Matt's there. Matt's been part of this. We've been together for about 4 years, and we're actually looking at alcohol policy in the spring, so we're excited about that as well. So the GVRO is one of these recommendations. We said, where can we get it? Where can we get our test case to do it? We said California. We drafted a bill, couldn't get anybody to introduce it. Everybody thinks California is so easy. It's not so easy. But the shooting happens. I've been shopping this op-ed from Renee Binder, who is a psychiatrist in California, member of our consortium, was the incoming chairman of the American Psychiatric Association at the time, could not get this thing published, okay? Shooting happens, resubmitted to the Los Angeles Times. 2 days after the shooting, it got published, and the very next day, Nancy Skinner introduces the bill that's been sitting around. It had been sitting around in good form. We worked on it. We had good science behind it. We had drafted it. We had experts behind it. And we got one of our experts to do some great, David, you're going to talk about this, media advocacy. That was probably the best op-ed I ever worked on, right? Right time, media windows open, great public health professional, medical researcher out there doing it. It really matters. And that voice, just like that, changed the debate. We also got consortium members to testify when the bill came up. We had 1 hearing left. If we blew this opportunity, it was over. The legislative session would have been over. Amy Barnhorst, who's a psychiatrist at UC Davis, testified before the California legislature in combination with a couple other people, and really did a wonderful job explaining the evidence and how this would work. And that was a big moment, getting that through committee. The other thing we did was we brought our researchers to meet with grassroots activists, to explain the policy, to show the science behind it. So we brought, and I've done this around the country now many times, this was the first forum that we did, to bring public health professionals and mental health professionals to meet lawmakers, legislators, law enforcement, and most importantly, the community groups who are behind this. And so there's Garen Wintemute and Shannon and Billy. Where's Billy? I think you were in that picture at the end. Billy helped to organize it. And it was really important. We got press, we got people to understand what was going on, and we aligned our allies thanks to the public health professionals in the room. Governor Brown went ahead and did sign that bill. He was very concerned about the due process concerns of that. And one of our consortium members, who's named Richard Bonney, who's a lawyer, we brought these different groups together, was able to write a memo to the governor and assuaged his concerns, and he went ahead and signed that bill. So we had great media advocacy, we had great allies, we did great organizing, but you guys have a role to play here. That's the point of all this, and I could spend a lot more time talking about this. But one of the best calls I ever got, this letter, is from Lieutenant Shui at the Santa Barbara Sheriff's Office. And I was asking him, how's the law working? And he sent me this list of examples where he's used it. And he said, hey, you public health guys, that's the best thing you ever did for me. That is like, you get law enforcement saying that, to me, that was great. And there's some great examples of how they've been able to remove firearms and save lives, very temporarily. This is not a long, these are civil orders, not criminal, very short duration. Other states have now done it. Washington did it by initiative. Oregon just passed it. 20 states have introduced it, and we expect more states will pass it this spring. It's been a really exciting process to do that, but it all started here in this room with great research, great creative thinkers, and having the members of the consortium engage as activists, okay? Not to say things that were beyond the evidence, but to present the evidence in op-eds before the legislature, to the governor, to the community, and it's a great model that I follow now. We've had a lot of other great successes that I will not go into, but this is the kind of thing, you think it, you dream it, you work hard on it, and you can make it happen. Yeah, sure, no. Actually, does David have slides? Do you have slides, David?
Thanks very much, Josh. So next up, we have David Jernigan, who is an associate professor here in the Department of Health, Behavior, and Society. David has worked in the field of alcohol policy, perfecting his advocacy work for, I won't say how many decades. Well, if he's willing to say it, then I suppose it's fair to share, for 3 decades now, and is just truly a master in terms of getting things done in the policy arena. He runs here the Center for Alcohol Marketing in Youth, and much of his work is focused around alcohol and youth specifically. And I'm very happy that you're here today, David. Thank you.
Thanks a lot. Let's see if I can make the slides work. Let's see. No, they're not going to show up, so I'll use the old version. No, it's not finding the drive, so whatever. Yeah. It's okay. All right. Thanks a lot for having me. It's great to get to hang out with the violence people. I usually hang out with the alcohol people, and the violence people are always really welcoming to me, and you've seen the data about why. But today I'm not here as an alcohol guy. Primarily, I'm here to tell you to do more with the media in all your spare time. So media advocacy, the strategic use of the mass media to support community organizing and advance social or public policy initiatives. I should say at the outset, throughout my presentation, I'm using stuff that Lori Dorfman at Berkeley Media Studies Group and her gang have worked on. They've done much more on media advocacy and violence specifically than I have, and they've got some great stuff. So why bother? Why should you talk to the media? Why should we spend our precious time doing this? Because there are 3 key functions of the news. They set the agenda, that is what we think about. They shape the debate, how we think about it, and they reach decision makers and drive the conversation about what we do about it. And in particular, they set the frames. They tell us how to think about things, the context. And Frank Gillimer talks about frames as a composition of elements, visuals, values, stereotypes, messengers, which together trigger an existing idea. They tell us what this communication is about. They signal what to pay attention to and what not. They allow us to fill in or infer missing information, and they set up a pattern of reasoning that influences decision outcomes. So framing is a translation process between incoming information and the pictures in our heads. All right, well, what's the picture in our head? The dominant picture in our head in the US is what Lori and her colleagues call the fundamental attribution error. That is, across the US society, people consistently see the actors and miss the stage. They attribute responsibility to personal characteristics rather than the circumstances surrounding the person, even when shown evidence about how the circumstances influence the individual's outcome. And this is because, and this is the big challenge for violence prevention work, is the default values, the default frame in the US is personal responsibility and rugged individualism. And if we don't consciously act to reset that frame, no matter how great our information it goes right back into the default frame, personal responsibility, and rugged individualism. So no matter how good Daniel's studies are about gun laws, it's my personal responsibility to obey those laws, and that's where it ends. And if they conflict with rugged individualism, I have cognitive dissonance. So what does this look like in the media? It looks like headlines like this. It looks like gun events, violence events as personal tragedies, as part of a lawless culture. And what do you do about culture? I love when we get culture explanations. What does anybody do about culture? It's just there. Okay, as opposed to increase in accidental deaths follows spike in gun sales, study finds. Or the GOP's latest gun bill would be catastrophic for women fleeing abuse, blah, blah, blah. What you've got there is two examples of setting agenda by taking action. The first is the release of a study, and this is our incredible power in public health. We do studies, we release them, and that's a huge opportunity to reset the frame, to set the agenda. And then the goal of that, of course, is to get a good controversial policy debate happening. Because that to me, I mean, I'm in alcohol, and people all the time are saying, oh, you know, alcohol, we just need to teach people more about alcohol. Really, they need the information. The information they need about alcohol is going to come through so much more saliently if it's in the middle of a lively policy debate. So what have we got in the news media? About violence, we've got if it bleeds, it leads. That is literally the saying, and this is some of BMSG's work. They looked at 6 California newspapers, and basically murder stories were 10 times as frequent, individual murder stories, 10 times as frequent as stories looking at larger aspects of community violence, violence at the community level, safety, community level measures, etc. They did another study where they looked at the topics of stories on sexual violence, and you can see causes way down there in the bottom corner. The most rare thing to be talked about is causes of sexual violence. What's happening here is 2 sets of frames. These are media research. You know, this is part of how we divine up the world. Episodic frames, which are event-oriented, specific, and concrete. They provide great visuals. They paint portraits. They're short, simple, personal stories, as opposed to thematic frames, issue-oriented, general. Landscapes, talking heads, data. They're long, complicated societal stories. Now, why do we distinguish between the two? Because it turns out, studies have found over and over again, you expose people to episodic frames, to portraits, and they will describe chronic problems such as poverty and crime, not in terms of deep-seated social or economic conditions, but as mere idiosyncratic outcomes, i.e., personal responsibility and the failure of rugged individualism. In the long run, this is Shanto Iyengar, episodic framing contributes to the trivialization of public discourse and the erosion of electoral responsibility, and here we are. BMSG 15 years ago did an analysis of violence and crime and did a quick look back recently to see if it was still accurate. Pretty much it was. News media report crime, especially violent crime, out of proportion to its actual occurrence. They report it as a series of individual events without adequate attention to context. They unduly conflate race and crime, particularly violent crime, and youth are almost never in the news, and when they are, it's usually connected to violence. So what we've got is a misinformation synergy here around the public's understanding of what violence actually is. It's a distorted picture of crime, a distorted picture of race, otherizing, makes it even easier to blame the victim, and a distorted picture of young people. And when prevention appears, what does it look like? It looks like more needs to happen in homes and schools to keep teenagers on the right track, or we need more state-mandated sexual abuse and assault education to elementary and middle schools, because you know, if we just teach them young and tell them over and over and over again, then social structure won't happen, won't matter, right? Wrong. So what we've got here is we've got the news media framing issues more often as portraits than as landscapes. So what do? The challenge is first to gain access, and there our great advantage again is we're making news all the time. But then most importantly, to win that framing battle, to shift the frame from the individual to the environment and point things towards a policy solution. So a little example, how we do this. Again, I work in alcohol, so these are where my examples are. So much research that has shown over and over in city after city that the more outlets you have in a confined geographic or population area, the more violence and crime you have, sexually transmitted infections, and so on. And here's the situation here in Baltimore. We have so many more alcohol outlets than we have McDonald's, libraries, or supermarkets. And this is, I love this. In media advocacy, we call this technique social math. It's taking numbers and making them mean something to people, often through ironic comparisons. We can frame this as an environmental justice story. That's one possible frame here. We have a wealthy neighborhood, Roland Park, and a much poorer neighborhood about 3 blocks from here, Greenmount East, with 5 times as many alcohol outlets in the poor neighborhood as the wealthy neighborhood. We can do studies in Baltimore, and we release them, we try to get news media attention for these, again, showing, as people have talked about, the increase in violence in a census tract that will occur with each additional alcohol outlet. Then this is what we want it to look like. This is Philly, and again, read down to the second paragraph. In partnership with the city of Philadelphia, Drexel's Urban Health Collaborative. So, there's a group there. They did some research. They released it. They got the right headline. Similarly, we've tried to make the liquor outlet thing here a part of a lively policy conversation. It doesn't make me enormously popular with a lot of people in Baltimore. And yet, this is part of getting the word out there, of reframing the conversation. Now, what do I mean when I talk about frames? The most important thing to think about when we talk about a frame is to think about values. And this is a place where those of us in science suddenly get very uncomfortable because, we do science, we don't do values. Well, the problem is that frames trump facts. If you don't set a values frame first, your facts will go into that default frame, and your point will be lost. The purpose of the research may be lost. Metaphors go along this, and these are a couple of my favorites from the violence side. From Barack Obama: if a child can't open a bottle of aspirin, we should also make sure she can't pull the trigger of a gun. Okay? Ironic comparison. Nick Kristof in the New York Times: to protect the public, we regulate toys and mutual funds, ladders and swimming pools. Shouldn't we regulate guns as seriously as we regulate toys? Okay? Then we need to tell the stories about how this fits into people's lives. What's it going to mean? How much safer will it make their neighborhood? How many lives will it save? Messengers are really important, and I am a parent, but I don't play a parent in the media. I play a geek. So we have people who look more like parents, because sometimes it's a parent that's the best messenger. Sometimes it's a policymaker. Sometimes it's often somebody besides you. The tone is really important, a reasonable tone. I learned so much from watching Kelly Conaway. I just can't stand her, but she's always smiling. She is, and she's always reasonable when she says the most outrageous things. And there's something to learn from that. So visuals are important as well. TV, there is no TV without visuals. And then the solutions, and making sure we make our solution as prominent as we make the problem. We can get so lost in the data about the problem, and we lose sight of what the solution actually is. So our task is to make the landscapes as vivid as the portrait, to illustrate the values we're talking about, to connect the values to solution, and then use communications to support action. These are the values. I have lists of these, et cetera. There are so many things that Americans across the political spectrum agree to. And if we can appeal to those values, we have a much better shot at being heard. So the last thing I want to say is don't ignore the pieces of the news channel that are self-directed, that are self-driven. I have a graduate student who has TA'd for my media advocacy course like 3 times now, so hopefully she knows this stuff. And sure enough, we had a terrible report from our comptroller about how Maryland's alcohol laws should be loosened to free up our poor imprisoned craft beer industry. I know you didn't know they were in prison, but apparently they are. And so she quickly put it together in an op-ed, and we worked together on it, and it got into the Baltimore Sun. The op-ed space is a powerful and available space. Even easier than that is the letters to the editor. I had a letter to the editor in the New York Times 2 weeks ago. New York banned alcohol ads on the subway, a great thing, but the story about it was all about the business of the subways and nothing about the public health effects. So it was an opportunity for me, again, to get in there, shift the coverage, get a public health voice into it. The last thing, a lie tweets halfway around the World Wide Web before the truth has a chance to log on. Twitter is an incredible platform that we're just beginning to understand. I hate it, so I hire somebody to tweet for me, but you better believe that we're tweeting. My center is tweeting. The algorithms that underlie Twitter are increasingly driving the news cycle itself. It's absolutely critical that we tweet, because if you don't like the news, gosh darn it, go out and make some of your own. Thank you.
Thank you, David. So our final panelist today is Demaine Millard, who comes to us from the Family League of Baltimore by way of staff positions and influence at both the city, state, and federal levels. So I know he has a lot to tell us, a lot to teach us with regard to politics and the issues that we care about. Thank you for being here.
Good afternoon, everyone. As the last speaker for this afternoon, I'll be sure not to keep you too long. I was asked and invited to, just kind of give some of the local context. I appreciate kind of all the public health perspectives. I thought it was very informative. I took a lot of copious notes. I am a Baltimore city resident, native, born and raised. And I think one of the key and core things that we recognize is just the humanistic value. And I think in terms of the shared values that you spoke to earlier, a previous hat that I had wore during my time here has been as the chief lobbyist for the city, and we were a part of a consortium of mayors against illegal guns. And during that time, I'll say 2008 or 2009, we had a package of legislation that we took to Annapolis. And with some of the challenges, which is no different than what we are dealing with right now in terms of aggressive homicides within our city, we had to come before various conservative committees. In the House of Delegates, it's the House Judiciary Committee, and then in the Senate, it's the Senate Judicial Proceedings Committee. Now, these are known to be committees not only in terms of, philosophical and political views, partisan related, whether it's Republicans, but also very conservative Democrats. And so you see some of the challenges and the issues that we were working in terms of making the frame were issues in terms of lack of local law enforcement, failed law enforcement, personal responsibility and accountability. Those were always the frames in terms of justification, in terms of not changing the laws that were on the books. And so even when you had the hard data and the elements that was really kind of making the case, we always saw the same result. Sometimes the legislation would just get a hearing, and then it would get left in the drawer of that chairman. And then the time would run out, and within the state of Maryland, there's a 90-day legislative cycle. It would basically be sine die, and that's it. The bill's gone. And so since that time, we've seen various mayors presenting that same level of legislation. And now it's interesting to see that the governor has proposed a crime plan for the city of Baltimore, and actually one of those includes, one component, includes some of the legislation that was proposed before. Now, this is a Republican governor. It'll be interesting to see in terms of how it will be viewed and addressed by some of his party colleagues within the respective committees. But just, again, from a local context, I think it's, interesting of note, especially when we're looking at the issues of race. And within the city of Baltimore, we're really to a point where it's 320 plus homicides. And if you're just looking at some of the data that has been prepared by the Baltimore City Health Department in terms of mortality data within the city, if you're looking at the top 5 leading causes of injury, death for Baltimore City residents, between the age groups of 1 to 4, homicide by firearm. Between the ages of 10 to 14, homicide by firearm. 15 to 19, homicide by firearm. 20 to 24, homicide by firearm. 25 to 34, homicide by firearm. So it's very grave in terms of some of the challenges that communities face right now. I myself can really recall at the age of 8, actually visiting a cousin not too far from here. Was a public housing complex called Lafayette Court Projects. And I'll just never forget driving with my mother, and she said, your cousin Randy, 10 years old, he was shot. Shot. What does that mean to an 8-year-old? That, in and of itself, stripped away a bit of my innocence at that point in time. And during the course, as a young black male, growing up in the city, it consistently chips away. You start becoming a little more immune and actually numb to it. So when it's a course of being at the wrong place at the wrong time, that's just something that's, unfortunately, socially here within various circles to be accepted. So I just want to say that as we're looking at this and as we're dealing with, I think, obviously heavy, weighty issues and being in this space with extremely bright and talented minds, I'm looking forward in terms of working with you all as partners and really being able to forge something in terms of truly impactful change moving forward in terms of policy reform. If any time in the country of Colombia, which has been ravaged with civil war, over a course of 25 years, and they've been able to see some remarkable declines in terms of violence, which has also had been obviously heavily entrenched in terms of the drug culture, and seeing in terms of messaging and how you're using marketing and advocacy to turn those things around and reform within the respective school systems. We can obviously do that in this great country and in this city. So I'm happy to be here with you and look forward to the dialogue as a part of our panel. Thank you for your time.
I'd like to invite all of our panelists up to the front here. And as you're thinking, well, perhaps I don't need to encourage people to think about their questions even before people are getting seated, please. Oh, yes, in the front.
Two people talked about the prevalence of responsibility as a frame. And I think it's important in some work that we did on reframing the way we talk about reproductive and other health issues. We turned that on its head. And we said, you can't talk, I want to be able to make important life decisions, but you can't ask us to be responsible if you don't provide the information and services we need to make those decisions responsibly. And this really opens up the sort of role for government, both in terms of regulation and access. And I think it's an important pivot that we need to think about.
Yeah, I think that's a great example of seizing that value for our side. You know, in my field, there's all this concern about underage drinking and all that, and I talk about adults having a responsibility to create the conditions where kids can grow up safely.
Absolutely. Yes.
I just wanted to ask about the sort of aligning the stakeholders question, and it really it comes up a lot. Yep. And I'd like to think that all of us sort of are on personally, I have to restrain myself, or I've had to restrain myself in the past, when I see massive coverage of mass shootings. And I want to scream, you know, what about urban violence? What about young black men? And these things. And it's a human understanding, but increasingly, I've come to think that these various constituencies have to support one another and can't be in competition with one another. In terms of gun violence, you know, 2/3 of gun violence is suicides. The next biggest chunk, just if we're talking about deaths, is community violence. And then there's domestic violence. All of these have a significant chunk. And then there's mass shootings, which I think, despite their extremely small number, have such a huge impact on the public that they deserve some attention. And I increasingly think we're not going to get anywhere unless all 4 of those constituencies work together and address these things. And I just would like to know, you know, your thoughts about that. Do you agree with that? How would you work towards that?
Well, I certainly would. I think it's important to be not only to work on it, but be fluent in all those different areas, right? So when in my organization, I not only, you know, think about urban violence and criminal justice reform and things like that, but also how does that, you know, suicide and how do you put those issues all together in a package? And I think there's ways to do it. The aligning the allies that I was mentioning really had to do with public health approaches, where there's a lot of folks who work in the mental illness space, especially consumer mental health areas, you know, really believe that autonomy and choice is a really important issue. So how do you harmonize that with an intervention that might limit that? So that really took a lot of effort, and that's why bringing the stakeholders at the beginning of the process is really important. Our last consortium meeting was on whether, this might be odd for us to think about this, but how do you actually restore firearm rights in a way that's both just and is also sort of meets public health criteria. So, you know, bringing those and having those stakeholders in the room from all those communities allowed us to address those issues. And so I think you have to be very cognizant of these issues. And the way to deal with that is not to develop a policy and say, do you like it? But rather to develop a policy with the stakeholders from these different sort of ideas in the room.
No, I totally agree. I think that there's more than enough room to have kind of a very strong and diverse coalition of support. I think it's needed to really mobilize and be able to generate that level of momentum for true and effective policy change. And I think I totally agree in terms of the number of stakeholders, really where you're able to get the different perspectives, whether it's from the various cross sections, you know, throughout the country, suburban, rural issues as it relates to suicides, but then also, you know, from the very nature of what we all have in common, the family connections, the community connections, especially when we're talking about community violence.
So I made Mark Kleiman's dream come true in Maryland, or we did. In 2011, we passed a 3% sales tax on alcohol. It's the first time the beer and wine tax had been increased since Nixon was president, first time the liquor tax had been increased since Eisenhower was president. And the way we did that was with a statewide coalition of 1,200 organizations. I worked with the NAACP. They just, at their national level, just passed a resolution backing alcohol taxes. We had unions, we had people with developmental disabilities, we had AARP, we had all sorts of unusual or not the usual suspects. We've done a study of 3 different alcohol tax campaigns in 3 different states, and in particular, the contrast between what we did in Maryland and what they did in Massachusetts is very much to your point, which is in Massachusetts, the effort to raise the alcohol tax was primarily done by the treatment community to put the money into a fund to fund substance abuse prevention and treatment, a field and a cause dear to my heart, but not a winnable strategy. They got the legislature to do it, and the industry took it to the ballot box and killed them. And so the lesson for me, I mean, all of us, we're working on these little issues, and we do have to find ways to come together more broadly. A couple of speakers before me mentioned the alcohol taxes. I mean, they are one example of just a huge opportunity, because passing an alcohol tax will have good effects on so many public health issues. I spoke to the National STD Conference last year, and they just don't believe it. They simply don't believe it. But, you know, one of the evaluations of the Maryland tax was it led to a 24% drop in gonorrhea rates.
Yeah, so I appreciate that comment, and I would also say, I think, David, it was you that spoke to the fact that, maybe I apologize if it was someone else, but I'm thinking of you, that spoke to the fact that the most violent cities that we see are those that essentially don't cooperate with one another in terms of their infrastructure. And perhaps this kind of cooperation around coalitions in favor of policies is a path forward to a more cooperative infrastructure generally that can support the kinds of violence prevention initiatives, be they about community violence, violence that occurs in the home, or suicide. We certainly have more in common, and certainly our interests are more aligned than they are different. So I think it bodes well to think strategically in that direction. Yes?
I'm thinking about the landscape versus the single frame. I'm thinking of Rosa Parks. I'm thinking of Emmett Till. I'm thinking about Black Lives Matter. All three movements emerge from single visuals. So I just want to make sure we don't over-eliminate the single story power, right? Yeah. These are movements that had logic and rationale, etc. But it is Errol Gardner, it is those single, it took a few, but it was the single story humanizing that made a movement.
Yeah, no, absolutely. And powerful stories are part of the frame. But the challenge with the news media is they will try to make it the whole frame. And Rosa Parks is actually a great example because most people know, that Rosa Parks was at Highlander before, months before she sat down on the bus, and she had a whole infrastructure behind her, and that there was a previous effort at a bus boycott, and they decided it was the wrong individual out front. And there was all this strategy there that led to the powerful Rosa Parks story, and all we hear about is Rosa Parks. God bless her.
Yes.
I have a question about the gun violence restraining order and partnership, maybe. I'm wondering, often gun lobbies say it's people, not guns. Mm-hmm. In this case, I was wondering if this kind of legislation is one where you don't get as much blowback from the gun rights and the gun lobby.
It's interesting. So, the gun lobby will say guns don't kill people, people kill people, and what we want to identify is the people who are at most at risk. So it's talk about framing. You're talking about playing in their frame. In California, they were really befuddled. They just didn't quite know how to do it, and so they got in very late and didn't give us a lot of opposition. In Washington State, we got passed by initiative. So they tried to do something publicly, but their frame hurt them. Their frame had said there are people who are too dangerous to have a firearm. So their messaging just fell flat on that. So, using that risk-based approach plays into a frame that's existing, and it's very powerful, and it's hard for them to then argue against it. So they end up on the margins talking about the due process concerns, but we built this directly on the domestic violence restraining order model. It's almost, we try to as much use whatever state statute exists to build the GVRO on same type of due process you get for a temporary DV order, and the same type of due process. So they try to argue on the due process part of it, but it's a much weaker argument.
In the back, yes. Dr. Rich.
So, many of us who care a lot about social justice issues also try and think about how to have those highlighted in the media. And so we think about inequality and talk about it. But the Frameworks Institute published this report saying, if you lead with that, then you kind of shoot yourself in the foot because you actually cause the opposite reaction to the response. I just wonder if you have thoughts about that. You posted some of the shared values, equality, fairness, but how do we balance? And sometimes inequality is actually the subject of the research. So how do you put that out? What are your thoughts about that?
I haven't read the Frameworks Institute report, so we'll start there. But I guess there are always two challenges in media advocacy, and one is grabbing the attention. And when we go forward with something that is not very specific, like social justice or like inequality, it is hard to catch people's attention. We have to make it real in their context. That's what takes us down the individual stories line. But then it's critical that we be ready to do the flip into, and the way out of this is this. And it's critical to understand that. All these sort of pivot phrases that can take us then into where we actually want to be. I don't know, that's the best I can do with it. And I guess one of the things we try to do in media advocacy is we try to find people, we call them authentic voices. People whose life experience tell the story of the problem that we're trying to address. And then we train them to do exactly that pivot. And my favorite example is years ago, I did a drink driving thing with a high school group in California. And we trained them and all that. And then we set up the interview with the journalist. And he wanted to do a drive along with her. And it was the classic thing where she's driving along and he says to her, "Now, how do you feel when one of your classmates dies in an alcohol-related motor vehicle crash? How does that make you feel?" And she was so great. She said, "You know, it just makes me madder when I see the ads on TV and they never show what can possibly happen. It's just not right." It's the pivot.
May I add just really briefly on that? The frames, frames have to be things that are unassailable American values. And so, some of the best frames, like it's no accident that the NRA uses freedom, right? Nobody disagrees with that. And so you've got to sort of take that away from them. So oftentimes in my class, I'll ask, is public health a frame? Is it a great frame? It is a frame, but a lot of people don't know what it means. So you want to use the words that are as simple as mom and apple pie, right? The more you get to that, and then create messages under that reinforce the frame. I think if you use what you said, inequity, was that? So to me, that's a very powerful frame. It's unfortunate that it's not a powerful frame for 100% of Americans. It should be, but I'm not sure, it's words like freedom and independence and rugged individuals and probably are a little higher on that level. And so if you can fit this group of messages and reinforcements under the highest level values, the most universally agreed to, the better you're off going to be getting your whole campaign going.
Fairness, level playing field, opportunity.
Yeah, that's.
Maybe one last comment, and then we'll turn it over to, we have two. Maybe so.
I was actually curious about any reactions to the Me Too campaign, sort of Twitter that took off and its impact and why. So it created so much movement.
I think it's great. I think it shows the potential of Twitter, and I wouldn't get completely carried away by it. And my guru here is, I'm going to butcher her name, but Zeynep Tufekci, who is the internet columnist for the New York Times and has studied Twitter and social media and social movements. And the point that she makes, which I think is so well taken, is Twitter can make something happen fast. But to make something happen long term, you've got to have the organizing behind it. And she's done the empirical work to show that. So that's what I would say.
And just on the Twitter note, you can use all sorts of different social media, but Twitter is where the influences are. That's the news media and everybody. It's a smaller universe, but it's a much more of influencers. And so that's why I think Twitter's become such an important venue.
And it has such an impactful kind of role, just growing organically and doing it so quickly. So now in a 24/7 news cycle, it becomes a power to be reckoned with.
And Mark, would you like to have the last comment? Okay. Daniel, then I'll turn it over to you. Thank you to our panel for making politics an opportunity.
Thank you, Shannon, and our last panel. I think that was really great. I always learn a lot when I hear these guys talk about their trade. I want to thank everybody for coming here. Many of you traveled a long way. Most importantly, also for what you contributed, your careful thoughtfulness that you brought to our discussions. There are a couple little, things that I have text I'm supposed to remember to say, like fill out the evaluation form. It is important. We want your feedback. Also, if anybody has a parking thing that they want validated at the table in the back, they will do that. I want to thank Josh Sharfstein and ask him also if he has some final remarks. I want to just say that there would probably not be a Bloomberg American Health Initiative if it wasn't for Josh Sharfstein and his creativity and passion to make this happen. And I just really am grateful to Josh. Josh, do you have any closing things you'd like to say?
I just want to echo your thanks to everybody. We've not only raised a lot of great topics, we brought together so many great people and different perspectives. What I found most interesting were some of the commonalities across the three types of violence that were discussed. I've been in meetings on each of them, never in a meeting on all three that really thought like what are some of the common factors that can be used to address violence more holistically. And I think that's a real theme that we'll take back because of everybody's willingness to engage with each other. So thank you, and thanks, Daniel. And please, I want to make an extra special thanks to the team that put this all together. Michelle, Akola Francis, Faria Zaman, everybody who worked behind the scenes. It's great to see it all happen.
Yes, just an amazing team, and thanks to Holly, my co-lead in the work group on violence prevention, and to our work group. And again, this isn't the last you've heard from us. We'll be communicating with you. We want to understand how we can, in partnership, achieve some of the fairly lofty goals that we have to advance the field. And we think that we can do that with your help and support. So again, my deepest appreciation for your participation in coming here. Thank you.